So usually I have 2-3 people in Apollo, so we'll usually refer to them. So one is Dr. Ramakrishnan and another is Prabhu. And I call both of them and Ramakrishnan, because this is one of the, what we are discussing is IgG4 disease. The Castleman's almost mimics an IgG4 disease. So Dr. Ramakrishnan, please enlighten us on both the disease.
Thank you very much, Hubal. I thought this is more a feast for thought, but it seems to be more feast for the palate. I think I should attend this monthly meetings. He keeps on giving me something to eat. In the process, I've started sleeping a little. Now, one important thing as far as, in fact, when this patient, I saw her first, I also thought very much in terms of IgG4 disease, because I jumped at the conclusion of her pancreatic disease and the IgG4 elevated to such high levels of heights. But what really troubled me was the fact that she was unresponsive to steroids, and that is something which should you bid you back. I do accept the fact that some people with IgG4 disease are unresponsive to steroids, where you may have to start them on rituximab, and I have had very good experiences with rituximab. But initially, IgG4 disease is something which melts with steroids. That's one important fact which made me feel that it is not IgG4. Now, we have to talk, just 5 slides. I'm not going to bug you too much about it. Now, if you take IgG4 disease, it's an immune-mediated fibro-inflammatory multisystem disease. And the basic pathology, you get like tumor-like swellings of the involved organs and organ dysfunction. Like invariably, people present with lacrimal gland enlargement, salivary gland enlargement. This is a very common presentation. In fact, people present even with pseudotumor of the orbit. Initially, they used to say this idiopathic inflammatory orbital disease, and later when we started doing the histopathology and getting into it, well, Dr. Ashok will agree that people started picking up IgG4 disease. So usually it becomes like a tumor-like lesion, and if it is a tumor which is present in a place, it can either cause anatomical dysfunction or physiological dysfunction of the organ involved. It is associated with elevated serum levels, 135 milligrams per deciliter. Not everybody has got elevated serum IgG4, but the majority have elevated serum IgG4. An important point is serum IgG4 should always be estimated in an empty fasting. That's very important. You can't give it postprandial, that's important. Now, anyway, we have people, Dr. Ashok here. I can't talk about histopathology, but there are certain important features which are quite unique as far as IgG4 disease is concerned. You have a dense lymphoplasmacytic infiltrate, and it's rich in IgG4 positive plasma cells. And important is the ratio of the IgG4 positive plasma cells to total IgG positive plasma cells should be more than 40%, or at least per each high power field, you should get more than 10 IgG4 positive plasma cells. And this is very pathognomonic. They have a storiform fibrosis. That's why we call it as a fibro-inflammatory disease. The fact that there is fibrosis associated with dense infiltration with plasma cells and lymphocytes. Some of them do have a phlebitis, which is in fact pathognomonic of the disease, and some people even have eosinophilic infiltration over there. The response to treatment initially is very fantastic with steroids. We usually start as 1 milligram per kg body weight, go for about 4 weeks, and then we start gradually tapering down the steroids. And then they may reach a stage when they're off the steroids also. If we are among the 150 patients of IgG4 I've seen, and the majority of them invariably had involvement of the lacrimal glands and the salivary glands or the pancreas. But there are very peculiar situations. There is one patient who had IgG lesions in the skin. Histopathology showed IgG4, classical histopathology, but they didn't know it was IgG4. Later it came to the lacrimal gland enlargement. We were able to correlate, seen lesions with people in the hypothalamus, in the region of the pituitary, and then people, retroperitoneal fibrosis is a common one, which is people, and then aortitis, periaortitis, and even involving, we've seen people with involvement even of the superior mesenteric arteries and all that. So what I meant to say is, what we are now seeing is just the tip of the iceberg as far as IgG4 is concerned. So high degree of suspicion should always be entertained when people present this. Now, what is this Castleman's disease? Now, I'm treading into the area of a hematologist. I think Dr. Prabhu is there in the last row. He's come, yeah. He's a very nice chap. Usually he comes late to the OP later than I, and so the meeting also I think he's come a little late. But he'll go late only, don't worry. Prabhu, you can join me because I think he's more competent to talk about Castleman. But just a few words about Castleman's disease, which I know from my point of view as a rheumatologist. I don't know like Prabhu, I'm sorry. It's a rare polyclonal lymphoproliferative disorder, so that's why we are fighting about this oligoclonal and polyclonal. It's very aggressive in nature if it is multicentric, and it has got an oncogenic potential of turning out into a lymphoma or a paraneoplastic pemphigus, especially when it is multicentric. And it is the greatest mimicry of IgG4 disease, related disease in the world. Multicentric Castleman's disease. Castleman's can be divided as monocentric or multicentric. Monocentric, just localized to one tissue. You do a surgical dissection, they are fine. Multicentric is something which I don't think even Prabhu would love to see because it's a very dangerous situation. And they have an elevation of serum IgG4 levels, and there is infiltration of IgG4 positive plasma cells in the histopathology. Now, I'm not going to talk about it. Pathologists are there. You have various types. Atropic, hypertrophic, sheet-like plasmacytosis is pathognomonic, and interfollicular plasmacytosis. And you have various three types like vascular, hyaline, and mixed. Now, why to distinguish between IgG4-related disease from multicentric Castle disease? Prognosis is different. I would like to have IgG4 disease rather than get into multicentric Castleman's disease. Treatment options are different. I shall tell you about it later. The mortality rate is higher in multicentric Castleman's disease. Oncogenic potential is great. IgG4 responds very well to steroids and rituximab, while in the contrary, multicentric Castleman disease responds better to ILC8 blockade like tocilizumab or cetuximab, and tocilizumab is available in the Indian market now. And the pathogenesis of IgG4 and MCD is different. This is a very important slide, the postgraduates. I'll definitely share the slides with them. You can take it off. IgG4 disease, the age of onset is usually beyond 50 years. Well, I'm at risk to develop IgG4. Castleman's disease is less than 50 years. Probably I should have developed it a long time ago. Orbital involvement, salivary gland involvement, lacrimal gland involvement, and pancreas involvement is common in IgG4-RD compared to Castleman's disease. History of atopy is common in IgG4. That's why you get serum IgG4 false positive elevation in people with atopic dermatitis. Splenomegaly is uncommon in IgG4-RD, but it is quite common in Castleman's disease. Lymphadenopathy is a little uncommon in IgG4 disease when compared to Castleman's disease, where it is quite common, very common presentation. Systemic symptoms. This is very, very important. IgG4 disease people are very well preserved. No problem at all. They look very fine. With lacrimal gland and salivary gland, they look very fine. But Castleman's disease, especially when it is multicentric, they are not quite fine. They have systemic symptoms. Elevated CRP is quite uncommon in IgG4. Its elevation is there common in Castleman's disease. Elevated IgA, I think that's a wrong word my secretary typed. Elevated IgA is more common in IgG4, uncommon in Castleman's disease. Polyclonal hypergammaglobulinemia is common in Castleman. The reason for it is being it's a very inflammatory disease. It is involved with the presence of interleukin-6. Nowhere hypergammaglobulinemia is more common in them. This is a point which I like to tell you, gentlemen, that IgG4 levels are significantly elevated in IgG4 disease, whereas serum IgG4 are elevated but may not be significant. But we have various exceptions to these rules. Histopathology is specific for either of them. Treatment, the drug of choice is steroids and rituximab, whereas when it comes to Castleman, it is IL-6, tocilizumab, or cetuximab. Nature, IgG4 is non-aggressive. Multicentric Castleman's disease can be aggressive. I just went through an article when there is a very rare presentation of a coexisting Castleman's disease associated with a pancreatic disease. I just picked it up. I will send these references to Ubal, which you can definitely share. Now the question is whether this person has got Castleman's disease or whether he's got IgG4 disease associated with Castleman. is only an academic quarrel which we can have, like in the parliament, but it doesn't make any sense. What we have to do is to treat the patient and not fight upon academic grounds. So this patient was treated with steroids earlier, which is unresponsive, and then we had to give her rituximab for the fact that she could not afford tocilizumab. She's doing excellently well in spite of the diagnosis and the treatment we offered. Thank you, Dr. Ubal.